Hello, I'm TDavis, Global Sector Lead for Health and Nutrition with World Vision International, and this is a presentation on the nurturing care groups and the care group approach. The nurturing care group project model is built on the earlier care group approach, so let's talk about that approach first. The care group approach is a community-based strategy for improving coverage and behavior change. It was developed originally by Dr. Peter Ernst and Dr. Muriel Elmer with Rural Relief and used subsequently by 32 organizations in 42 countries. Dr. Adunya Kebede and I were among the co-pioneers of this approach. The approach focuses on building teams of volunteer caregivers who are mostly women who are selected by their peers and represent, serve, and do behavior promotion with blocks of about 12 households each in their neighborhood. Care groups are plug and play and have already been used to partially or fully promote many health and nutrition and WASH behaviors. Care group volunteers are pure volunteers. They receive no monetary incentives, just job aids, yet we usually see only a 5 to 10% annual dropout of these volunteers. Their workload is kept very low, less than 8 hours a week, to avoid burnout and exploitation. And evaluations at the end of care group projects have shown that one of the main reasons that women remain as volunteers in this role is that they gain respect in their communities and find the role empowering to them. The care group approach has been used in both development and humanitarian settings, including after disasters. The way training is done is part of the project model. It's similar to drip irrigation in agriculture, just a little at a time, through regular 2-hour meetings every 2 weeks instead of a week-long training, which can be overwhelming to volunteers, especially when they're illiterate. In this way, volunteers get over 100 hours of behavior change training every year. During these bi-weekly care group meetings, a care group promoter, who can be a Ministry of Health community health worker or a paid NGO staff member, meets with the care group volunteers. The volunteers report on things like progress and challenges in promoting behaviors. And the care group promoter demonstrates how to promote this week's 2 to 3 behavior change messages using a flip chart. There's a group reflection on the messages that the volunteers practice behavior change promotion with the flip chart in pairs, with the promoter supervising and coaching them along the way. There are other evidence-based behavior change activities in the lesson plan, like helping people to identify barriers and then brainstorm on overcoming those barriers and making commitments to changes. A mix of songs, dramas, and games are used during these meetings and contacts as well. Now, what happens after care group meetings? Well, after this bi-weekly meeting with the promoter, each care group volunteer meets with her neighbor circle, a group of caregivers from about 12 surrounding households, the households whose caregivers selected her, and she promotes behaviors using a small flip chart. Group meetings are at the neighborhood level, not at the community level, which helps increase coverage and makes it easier for caregivers, both mothers and fathers, to attend the meeting. Contact between the volunteer and each household is done through a combination of individual home visits and neighbor circle group meetings. Caregivers who miss a group meeting also get a home visit. Most vulnerable families also often receive additional attention, as do parents with a newborn child. One option with this project model is to do outreach to fathers and grandmothers through separate groups that usually meet less often, such as every 2 to 3 months. This is called the trios modification. The care group promoter directly supervises the behavior change promotion done by one of the care group volunteers in the group every 2 weeks, watching them do an actual group meeting or a home visit. And this full cycle of behavior change lesson plans are usually repeated after about 18 to 24 months. Here's a diagram of the care group structure, which is the same as a nurturing care group structure. With nurturing care groups, you start with a census, which targets all households or every household with a beneficiary, for example, a pregnant lactating woman and children under 5 or under 2 years of age. so there's flexibility on which households are included. Next, the caregivers in each group of about 10 to 15 households, see the far right, select a volunteer who will serve them. These nurturing care group volunteers are then trained every 2 weeks in groups of about 12, either by that paid nurturing care group promoter who works with about 5 to 9 of these groups, or a first-tier community health worker who works with only 2 groups of nurturing care group volunteers who are considered second-tier community health workers. The groups of volunteers are the nurturing care group, and the groups of caregivers are often called neighbor groups or neighbor circles. The nurturing care group promoters are supervised by a supervisor, and when a community health worker is in that nurturing care group promoter role, they're usually supervised by health facility staff. The nurturing care group volunteers learn a new behavior to promote every 2 weeks and then cascade that down to the households that they serve through home visits or a group meeting. The nurturing care group model is essentially a behavior change platform. The project model that World Vision is using, and that many other NGOs are welcome to adopt as well, is built on this care group approach, and we call it the Nurturing Care Group Core Project Model. The main difference between the care group approach and the NCG model is that the NCG model is used to promote behaviors associated with most elements of the Nurturing Care Framework, which was released by the WHO and UNICEF in 2019. A diagram of that is shown in the bottom right here. The aim usually is to reach every household in the program focus area or the entire program impact area with this holistic child well-being behavior promotion. The model is used to promote basic parenting skills and adoption of key behaviors from all sectors. Nurturing care groups are considered a behavior promotion model at the individual and household level. However, by reaching every or most households, it can also change community norms. Note that it can easily be combined with models that focus on the community, enabling environment, or policy levels, such as citizen voice and action, COM, and channels of hope. And sometimes PD Hearth or CMAM are also done alongside of the nurturing care group model integrated with it. One of the core outcomes of nurturing care groups and the care group approach is multi-sectoral behavior change. Behavior change is important because 55% of all child deaths can be reduced through behavior change interventions alone. Behavior change can be relatively inexpensive, and when behavior change programming is done right, it can have a significant impact on reducing child deaths, malnutrition, violence against children, and other things. The maximum workload for nurturing care group volunteers should be no more than 8 hours per week. The recommended ratios and group sizes are all built into this model to maintain this light workload. Non-monetary incentives are recommended for volunteers and not paying them. This can include things like community and neighborhood recognition, like asking community leaders to recognize the volunteers at events, giving each one of them a badge, and providing them also with work tools, things like their flip charts, the wraparound skirt with child well-being messages put onto it, or other things. NCGVs should never be paid like staff. Paying them can create jealousy among neighbors and crowd out other intrinsic motivations. The few projects that have tried to pay care group volunteers had to close down the program due to these problems. However, we continue to advocate for governments to pay all workers who work longer hours. For example, community health worker volunteers who work 20 to 40 hours a week, they need to be paid. NCG lessons and flip chart images have been created for health and nutrition, including mental health, WASH, education, and child protection. Lessons to promote livelihoods behaviors are in progress. Note, this model can be used to promote behaviors across all of World Vision sectors and for the spiritual nurture of children where that's appropriate. It's recommended to promote behaviors from as many sectors as possible, as this will lead to a more holistic child well-being outcomes across the nurturing care framework. In practice, if you use the care group approach or the nurturing care group approach to promote behaviors in only a single sector, you could still use all of the nurturing care group materials and the latest training manual, but please refer to it as a care group approach project rather than the nurturing care group core project model, since you're not promoting behaviors across that entire framework. So let me show you why we're excited about this project model. In a word, it's better. It's better and more cost-effective than other behavior change models we've used in the past. It outperforms. This study was on a large Food for the Hungry care group project in Mozambique that I helped design and support that reached a population of 1.1 million people through more than 4,100 volunteers, leveraging more than 2.4 million hours of volunteer service. More than 4,100 neighbor groups were formed during the project. And in that project, which ran from 2005 to 2010, we saw an overall 38% reduction in underweight in children in less than 5 years. We also saw excellent results in terms of adoption of health, nutrition, and wash behaviors, and an estimated 36% decline in under 5 child deaths. And we did this at a cost of only $2.78 per beneficiary per year. And that cost includes all project costs, backstopping costs, training, indirect costs, everything. The cost per life saved was only $441, which is 5 times less than the average child survival project. And the cost per case of malnutrition averted in the project was $138. In analysis of multiple care group approach projects that we did in 2015, we found excellent outcomes across the board. The cost per life saved ranged from $441 to $3,737, which is 7 to 136 times lower than threshold for highly cost-effective interventions set by the WHO. This approach has also been used after disasters. Here are some results from use of care groups in post-earthquake Haiti and an OFTA project. Note that many of these wash changes are 20 percentage points or more, and these changes were brought about in only about 12 months. This is very rapid recovery. Goal Ethiopia also used the care group approach during a slow onset disaster. The East African drought of 2011 was reportedly the region's worst drought in 60 years. And despite the drought, Goal saw a decrease in the proportion of children who were malnourished from 28% at baseline to 20% at final, where care groups were used, which is a very large improvement. And it compares very favorably with an increase in malnutrition to around 30% in other nearby areas and the Sidama region as a whole, where care groups were not used. They also saw improvements in nutrition indicators in this drought with using care groups, such as a 32 percentage point increase in children fed a minimum adequate diet. The final evaluation notes improved coping strategies during times of drought and strengthened links with health posts. More recently, a randomized control trial by researchers at Tufts was done of the care group model in Burundi, one of the poorest countries in the world. Care groups were combined with food rations and some light health system strengthening there. And the researchers found that the care groups plus rations approach reduced child wasting approximately by half compared to controls via prevention of wasting. This was during a period of decreasing food security. This approach also reduced stunting and anemia, increased household food security and diets, and improved motor and language development. So this could become a dominant model for building resilience and reducing malnutrition around the world. Here's some data from another care group project in Liberia that had the best improvement in child nutritional status and wash outcomes that I've ever seen in any projects. And I've worked in this area for 37 years. A 65% reduction in underweight in only 4 years. That's unheard of. In Cure America's Global projects, they combined the care group strategy and some WASH inputs to achieve these results. There's a lot of information here, but look at that last column. The indicator gap closure is a measure of what was achieved versus what was possible to achieve given baseline levels. And note that there's a 65% gap closure for the impact indicator in this care group project, the percentage of children who were underweight. And for the other indicators, many of them almost reached perfection, close to 100% closure of the gap and close to 100% closure coverage by the end of the 4-year project. For 40 of the 43 indicators that Cure Americas measured, they closed more than half of the indicator gap. This approach has been used in very successful malaria projects as well. For example, these are the results of a Rural Relief Care Group project that trained 2,315 care group volunteers on malaria prevention and care seeking that reached about 24,000 households. And among the results they saw was an increase in insecticide-treated net usage from 1% to 85%, an increase in care seeking for fever, where they suspected malaria, from 28% to 90%, and a reduction in the incidence of fever from 50% to 6.6% in only 4 years. Note that most of those increases were achieved by midterm within 2 years, and that's not unusual in projects using the care group approach. This model has also been used for TB control, where the treatment success rate rose from 79% to 93%. So as we saw this data coming in on this project model, some people were saying that the remarkable results might be because organizations implementing care groups were remarkable. Or maybe it was because the countries where we intervened were easy countries to work in. But that was not it. This 2015 evaluation that I co-authored with Johns Hopkins researchers compared the effectiveness of multiple care group projects in 5 African and Asian countries to other USAID-funded child survival projects that did not use care groups in terms of coverage of key child survival interventions and the under 5 mortality rate. This table shows the mean changes in adoption of behaviors of care group and non-care group projects. So for example, hand washing with soap rose 20 points on average in non-care group projects, not bad, but 43 points in care group projects. In this study, 10 care groups and 9 non-care group projects were matched by country and year of program implementation for comparison, and they all had very similar budgets. That evaluation found that care groups had double the behavior change of non-care group projects and may have had 53% greater under 5 mortality reduction. I won't go through all of this, but feel free to pause the presentation and read through these results of using the nurturing care group model to reduce harsh punishment against children in Ghana. We compared results where nurturing care groups were used to control areas where they were not. So this is very high quality evidence showing that nurturing care groups work very well in reducing violence against children. Note that these results were achieved by staff working in the WASH sector, not child protection staff. So even if you have staff who want to use this model to promote behaviors outside of your sector, that is no problem whatsoever. The WASH impact of the same project in Ghana was also incredibly good. These graphs show decreases in bacteria in drinking water, proof that hand washing with soap increased, and that people were petting their animals during the day, which is a way to decrease stunting in children. The yellow lines show these improvements in areas where nurturing care groups were used. And the blue lines are the control areas where nurturing care groups were not used, which saw non-significant changes. These results are often highly sustainable as well. Sustainability studies on care groups by Rural Relief and the researcher Halkan Otura found high sustainability for outcomes. For example, Rural Relief found 93% of care group volunteers were still active 20 months after the project ended, and half of the women in communities have received a visit from the care group volunteer in the past 2 weeks. Measurement of indicators at 2.5 and 4 years post-project found that all results achieved by the project were sustained or improved years later. This graph shows the increase in the percentage of children fully vaccinated in the project from baseline to final, for example. The blue line, and then maintenance of the rate above 90% at 36 months post-project. A similar graph is shown on the children who received treatment for diarrhea, and they had about 16 other graphs that looked very similar. A separate study by Tura in 2017 had very similar findings. Note that the care group approach has been used in development, rural, urban, and fragile and emergency contexts. This is a new core project model for World Vision and for other organizations. It's been used in Ghana to promote behaviors in 3 sectors and is being used in a somewhat modified way in Tanzania with adolescents. World Vision has used the earlier care group approach in quite a few countries, including the one shown here. This model can make a big difference in child well-being outcomes in a short amount of time at a very reasonable cost per beneficiary. I highly recommend that you consider using it and scaling it where you work. Thank you very much.